Welcome to our attendees who have joined us today and to those joining via the recording to the North Simcoe Muskoka Specialized Geriatric Services Practice Short for April 2023. My name is Kim Simpson and I am one of the Psychogeriatric Resource Consultants with NSM SGS. We're going to start with a land acknowledgement. We are gathering on traditional lands sacred to many Indigenous nations. I would like to acknowledge the traditional territory of the Anishinaabe, which includes the Odawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy, the Haudenosaunee and Wendat nations, and the presence of other First Nations, Métis, and Inuit residing in Simcoe Muskoka territory. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. As such, we commit to collaborating based on the foundational assumption that Indigenous peoples have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nation, Métis, and Inuit people. We are pleased to provide our practice shorts through Zoom webinar. All participants are muted and videos are off. Please note that there is a chat box at the bottom of your screen for you to share with other participants and a Q&A section where we would ask that you write any questions for the speaker. Please do not click on any links in the chat box unless they are provided by myself or Alison Jayawira. Today's session is being recorded and will be accessible on the SGS website. If you are watching the recording, welcome. And a reminder, if you would like to join live, practice short sessions are offered the second Friday of the month at 8:30 a.m. I am pleased, advance the slide please, I'm pleased to introduce Dr. Geoff Daniel, Consulting Geriatric Psychiatrist with the North Simcoe Muskoka Specialized Geriatric Services Mental Health Team. He has worked with 5 different outreach teams in all imagined settings, has always been an educator, both formally and informally, dabbled in research, co-authored an article and a toolkit, and has done tremendous work in administration and leadership. His mountaintop moments include mountain biking, cross-country skiing, under the blue sky, memories of Creemore Bank Cafe carrot cake. Welcome, Dr. Daniel. And I'll just acknowledge that Dr. Daniel is having some connection issues, so he may shut his video off as he presents. Welcome.
It's a pleasure to be here. And it's a challenge because we're short of time and I sometimes talk a wee bit much. So I'll forge ahead. And I put up the slide, of course, of the objectives of what I'm trying to talk about. And really what I'm trying to do is talk about how can we use meaningful questions and how can we get an understanding of one's life experiences, because that's going to assist us in managing what's in front of us in the here and now, in the current situation. And that helps both management, treatment, and just planning, care planning, etc. The other thing I'd like to touch on is the concept of how if one takes the time to hear the older adult's life story, not simply about the current situation, one can get insight into the individual patches that create the quilt, and that all of that patchwork is the person. So I just wanted to start with some disclosures. As Kim mentioned, all quilts are my wife's creations, and so we get a little buffet of different quilts to look at. I wanted to comment how Kim was fabulously helpful to me, as always, and Kim was helpful, Alison was helpful to Kim, but I felt obliged to say, well, Alison was helpful a lot, but not fabulously. You'll notice in the asterisks, oh my goodness, I put it in small font, that Alison has been known to be fabulously helpful in the past. But in this scenario, Kim was sort of the lead helping me. I also wanted to mention that Helen Ball was a social worker that was working with me when I was director at Homewood of the Geriatric Psychiatry unit. And in 1996, she started talking about the narrative of quilts. And in fact, fun fact, she got her PhD, in fact, on a dissertation on quilts as a social text. Not so much in the older adult, but it did get me thinking, and I've never really forgotten that. So most of us, certainly our team starts the assessment with a comprehensive geriatric assessment. And the point there is that this is an excellent geriatric assessment for both GeriMed and GeriPsych mental health team uses it, but really it only gives a nod to the psychosocial spiritual aspects, and it really is more on the current and only briefly touches on the depth of the narrative of their lives. So one has to then consider, yes, this will guide us in the current presentation of the person. That's one patch of the quilt, and often when we're involved, it's a dark patch of the quilt. So we need the whole quilt, and so you'll notice that little black circle is that patch in the current, but the whole quilt is the person themselves over the lifespan. And just some fun facts about quilting, not that I'm an expert, but quilts are generally made up of different parts. And the cool thing is one can really milk the metaphor idea when you think of a quilt. So today we're talking about the quilt top, the fabric pieces. They're actually called pieces, nothing to do with Ken LeClair's pieces, but kind of a fun connection. So these pieces are all sewn together and they're connected with thread, which holds the pieces of one's life, the chapters of the book together, as it were. There's backing material, there's batting, which is about adding substance to that life story. And often, depending on the batting, the quilt is more or less and the quilting itself and the binding have metaphors as to how the person's held together and what's hidden in terms of raw edges. But for today, we're going to focus on the quilt top. The next piece is, oh shoot, sorry about that. So that's what I was talking about. Now the next piece is when we look at a person, that person in front of us brings with them their past, their symptoms, their lifestyle choices, their past experiences, good and bad, and that influences or colors the current symptoms, behaviors, likes and dislikes, etc. So today's about looking at that past. And I should differentiate that, when I talk pre-morbid, I'm talking the past that is before the onset of the dementia. So it's pre-morbid to the dementia. And that becomes essential. But getting back to this stick person, whether it's past or current, there are certain things that sort of encircle that person through their journey. And one is the social determinants of health. And I'm not going to dwell on that, only to remind you that considering social determinants of health is an important thing, and particularly in determining outcomes of physical, mental, cognitive health. But the other thing that we carry with us over time is the conscious and the unconscious, which is to say that in the current, we will have a response to something, i.e. responsive behavior. And there is an element that is interacting with what is known, what is realized, what is conscious. But even in those reactions, both ours to them and them to us, there are unconscious factors as well. And the best example I can give is a bit of a trauma trigger warning. But, if there is a man in long-term care with dementia, and he's violent, and he hits a person, a worker, that worker, in the real relationship, in the conscious interaction, that worker is going to feel, hurt. They've tried hard to help this person. They're going to feel sad. They're going to feel outraged, perhaps angry, and that's all real. But if that worker also was hit or beaten by their parent, particular father, and that it's a male to male thing in this example, they're going to feel all those emotions 100 times. It's not a bad thing. It's just important to be aware of what might be influencing our reactions. And by understanding a little bit about the patient's past, one might have a guess as to what might be unconscious in that person's response in the moment. For example, somebody who has suffered abandonment may unconsciously fear that abandonment is going to happen again. and that might drive their behaviors in a facility setting. So our challenge becomes, all behavior has meaning. That's a vital idea. And the challenge then is to figure out the meaning. And this is something I like about the work and behaviors of dementia, because it allows us to be creative. It allows us to think out of the box. So the challenge then is, how can we be more effective? How can we be more effective in managing that person and helping them with their distress, in settling them and helping them have a sense of dignity? And really the fun part is that you get to develop the detective in you. And by doing that, you need to ask the right questions. And again, in terms of exploring the premorbid, there's really two parts of those questions. One is a checklist, particularly for those who are diagnosing, or those who are trying to notice a pattern of symptoms or behaviors to see what might be happening in the current as well. And so there's some standard checklist-like questions I'll run by you. But then the nuance is to allow the follow-up questions that you might have to be driven by the narrative. So you're listening to the person, you're reading between the lines, you're listening to the cues, and that will give you an idea of where to follow up. In other words, out of all the pieces of that quilt in front of you, which pieces seem important to that person or may have colored the way that they are in the current. So this is a slide from the algorithm, actually, in the antipsychotic and long-term care toolkit that's on the NSM SGS website. And the issue is, when I'm in the trenches, I found myself thinking about, what's driving this behavior? Because my task was to both diagnose, but then prescribe or suggest treatments of medication, and also trying to assist with the non-pharmacological thoughts and ideas of what might help. So, the first four factors are diagnostic conditions that might be driving that behavior, and that will help also for you diagnosticians and treaters out there, might help you in which medication to choose as a first. So depression is important because irritability is the #1 symptom of depression in the older adult. Psychosis clearly will drive behaviors if one is paranoid. And I'll mention again through the talk, because it's important, that you have to remember delusions of jealousy, whereby, it's usually the man is dementing, goes into long-term care, eventually realizes his wife isn't there, and then starts assuming and thinking and becoming convinced that the man at the supper table is sleeping with his wife, and violence can ensue. Hallucinations can also drive behaviors in that realm. The frontal lobe symptoms are really about lability, and that's different than a fluctuation in attention. This is lability and moods, sort of 0 to 60 or 0 to 100 for you young folk, in a change in mood. And that might be something where one reaches for a mood stabilizing type of medication. Delirium, of course, is about that fluctuation in the ability to focus or attend over the hours. And then there's other things such as pain, medical conditions, side effects of meds, substances, etc. But the other thing that is on this list, of course, is premorbid. In other words, gathering information about the premorbid situation. And so one asks the patient, one also gets permission to ask family members. And so this is a bit of a cluttered list, but it's sort of getting at what might be on that premorbid checklist. What areas, when I'm asking about in the past premorbidly, what areas do I want to tick off? And certainly, obviously, one would be depression. And the idea would be, is it episodes of depression? Is it all the time depression? Are there substances driving that depression all through their life? Is it actually clinical depression, major depressive disorder, versus depressive symptoms such as existential demoralization? You want to check about past suicide ideation attempts. The issue of moodiness then tries to touch on temper, cycles of mood. It gets into the realm of, is there hypomania or mania? That is bipolar disorder. And I'll talk a little bit about that. Remember that hypomania can actually present as more irritability than euphoric or expansive mood. And so sometimes you see somebody who is having a great deal of irritability, some sense of cycles of that irritability, and it can be the issue of a bipolar situation. In terms of premorbid, you also want to touch base in terms of violence as well. Another checklist item would be anxiety, and I'll speak to that in a little bit. OCD, sometimes we see people with the obsessional behavior, compulsive behavior, psychosis I've mentioned, don't forget the delusions of jealousy piece, and of course, substances, if they have access to them, of course. This can include prescription medications as well. The other part of the premorbid checklist are things like ADHD, which is often missed in the older adult, but can certainly color the presentation of the person in front of you, whereby they have a lot of blurting or a lot of impulsivity, for example, that might be attributed to something else. And in a small group of people, treating it as though it's real ADHD can actually help. I always want to talk about trauma, and Gabor Mate got me thinking about the idea of, big T trauma versus little T trauma. And I'll speak to that as well in the next slide or two. In terms of personality, I'm really trying to pick up, is there paranoid personality over the years? So maybe the person wasn't, having a massive false fixated belief of paranoia delusionally over the years, but they had this suspicion, and they had sort of a susceptibility to taking a paranoid stance. Borderline, I'll talk about, narcissistic dependent, and the OCPD is the obsessive compulsive personality, which sometimes can be the perfectionistic, always on time, somewhat critical person. And fun fact, they don't tend to age all that well. Exploring ideas of sleep as well would be prudent. So I wanted to also kind of list an idea of, well, what questions would you ask in terms of this? And so, when you're talking about major depressive disorder, I want you to try to differentiate, the criteria for that is at least 2 weeks of, depression, low interest, depressive themes, woe is me, there's no hope, etc. And that would be an episodic thing through their lives where they get back to their normal baseline in between, versus the person who is chronically depressed, which is now called persistent depressive disorder. A few years ago, it was chronic major depressive episode, and a combination of that and dysthymia, where it's 2 or more years of, more often than not, a depressed mood, hopeless kind of presentation. So it helps me understand, particularly, is that worth trying an antidepressant? Well, especially if there's an episodic depression, for sure. If there's chronic depression, one starts to dig for, what other things, marital kind of things, etc., what might be contributing to that depression. Premorbid around the moodiness would be really digging down on the cycles. Particularly the irritability cycles. Did family have to walk on eggshells? And sometimes mom or dad would be just irritable, intrusive, argumentative, and it would come in cycles that would last 2 or more weeks. Or was it sort of a constant? They were always irritable, always looking to pick a fight, which is not a bipolar story. Or in fact, we have to remember, are those periods of irritability related to substances is an important question. Also, when I ask about alcohol, I found that if I say, a question about, were there any concerns about use of alcohol, people might assume I mean hard liquor. So I always say alcohol, and then I add quickly beer, liquor, or wine. In terms of generalized anxiety disorder, this is the person who is a worrywart. So I ask that. For example, was mom a worrywart? I might say to the family. And these are the people with a high baseline of real life worry. It's not like an OCD, intrusive worry. um, Social anxiety, or were there concerns about, social performance? Did they always avoid being the center of attention in the group or avoid social situations? And remember that panic is actually out of the blue. It's truly out of the blue. It's not precipitated typically. Um, the other thing to think about then is the idea of ADHD. If you're getting a family history or a story of disorganization, poor time management, acting before thinking, procrastination because of distraction, then do an ADHD checklist. Personality disorder, I really try to hone in on concepts of suspicion, manipulativeness, rocky interpersonal relationships, self-centeredness, dependency, perfectionistic. Because I find that those are often the key issues that really get in the way of how people respond to perceived or real insults, etc. Um, Again, don't forget the delusions of jealousy when asking about questions. And if there is an issue of sexual expression of risk in the current, one needs to ask a lot of detail about premorbid sexual behavior and attitudes to get a sense of how high is the risk? Is this totally new? Is it for an issue more of the frontal lobe deteriorating? And the trauma is interesting. I mean, again, the big T trauma, things like sexual assault or other types of assault, war, horrific accidents. But I've come to realize that, there's the little T traumas too. And Gabor Mate talks about hungry ghosts, that when we have disorders of attachment, we don't attach properly as a child, or we don't develop authenticity. We don't feel our voice is authentic or allowed as a child. We start to have sequelae as we live our lives, and as if these hungry ghosts, these needy hungry ghosts with an emptiness inside of them, follow us. And he started first with the idea of this drives addictions, but I think it also speaks just to sometimes people who now in the current are very reactive to abandonment, or very dependent on the staff, etc. Not necessarily, but one needs to think about that scenario. Some other questions to think about is just the idea of purpose and meaning. And I'm a big fan of purpose and meaning. And one needs to think premorbidly, well, what was their life role? What including occupation, but what gave them purpose and meaning in terms of spiritual stance, or specifically a religious stance? Viktor Frankl talks about, people find purpose and meaning from what they gave to the world, what they took from the world in terms of experiences, etc., and how they face their suffering. And so exploring that a little bit gives us a sense if they were always somebody who had meaning, have they lost their sense of purpose and meaning, etc. This opens up the whole avenue of trying to address or encourage them to redefine their meaning, or encourage the religious person to continue their relationship with God, even though they're in a nursing home, and to serve God, etc. And then you want to think about things that sort of, there's a lot of frameworks out there. There's the My Personhood Summary from the BSO 2022. And they really get into sort of who and what soothes the person, who and what triggers that person over the years, interests, occupation, significant dates becomes important, etc., etc. Also gets into, the way the person expressed their feelings, managing stress, etc. So there's a lot of experts in the room that spend a lot of time on the non-pharmacological stuff. So I just wanted to touch on that. Plus, I'm running out of time. But those are the kinds of things to ask. The final point really is utilize the team. So you have a team in various settings of different disciplines, different expertise, different roles. And so you want to sort out, okay, in terms of looking at premorbid specific for this talk, what do we already know? Because we don't want to duplicate the questions for the patient or for the family with consent. We don't want to sort of redo the wheel, as it were. And then there's different team members will use the information differently. Rec therapy might want to focus on the purpose and meaning, past interests, etc. So who uses it, how is it used, and how does the team share it becomes very important. And the practical takeaway as well is that listening and knowing the pieces of the person quilt really honors their story and maximizes their sense of safety and dignity. And it optimizes your effectiveness at helping them while minimizing their distress, their responsive behaviors, etc. And these questions are not just a checklist. It's about listening to the clues, to guide your further questions, to sort out the narrative, identify those key pieces of the quilt. And the final piece is, the person is really the expert on their story. So ideally, they have the capacity, the cognitive capacity to share that story would be the most useful and accurate. So I'll stop there and open up for questions.
Great. Thank you, Dr. Daniel. That was quite informative. And I really appreciate how you're trying to, it is an art about how to see the whole quilt and how to be mindful and when we're doing assessment. If anybody has any questions, feel free to add them to the Q&A. Got some comments in the chat box if they're ready for a part 2. I know that Dr. Daniel was agreeable to sharing a couple of the slides with those specific questions. So we will add those to the chat box. When we met to talk about this, it really is, if you've had the privilege to participate in assessment, there really is an art and a skill in trying to mine some of those questions so that we can broaden that across the sector. So I do see that there is a question. Is there any relation of paranoia to loneliness in your experience?
Chicken or the egg is my first thought. So, people who are paranoid tend to prefer, I suppose, to be lonely. It's certainly, the paranoia could drive one towards loneliness and perhaps also exacerbate the paranoia. Probably the question is more this COVID isolation and loneliness. Can it develop paranoia? I can't quote literature, etc., but my instinct would tell me to go that far, you'd probably have sort of a susceptibility. Maybe somebody who was paranoid personality, so they were suspicious, they were susceptible to conspiracy theories, etc. Not all people, of course, who believe in conspiracy theories are necessarily paranoid personality, but my point being that if you had some sort of strains of suspicion, hypervigilance, it might worsen with social isolation and loneliness. Perhaps it would then bridge into a fixated false belief, not in keeping with society, which is the definition of a delusion. But I would think you'd have to be loaded for that. I don't mean with alcohol, I mean genetically.
Yeah, great. Thank you. And I am mindful, you did start your talk out with saying we don't have a lot of time. So I'm mindful that it is coming closer to 9 o'clock. So if you do have other questions, feel free to add them in. Lots of accolades in the chat for thanking you for a great talk. I am going to draw attention to the group for next month's talk. So we are really pleased and excited to have Rebecca Barnstaple join us. She's the Manager of Community Programs and Engagement at Shikamek Community Health Center. And she's really going to be presenting on her research and the innovative work that she's doing in our region. So the registration link for that is available in the chat box, or you can find it on the NSM SGS website. As always, it's a free event, but registration is required.